So, hello again, and welcome to the second part of the topic of toxicology. I had covered the first part of it a few weeks ago, and I think the last that I spoke about was toxic alcohol poisoning, and that was the last topic that I'd covered. So today I'll start from a very important topic called serotonin syndrome. It is a very favorite topic from an exam point of view. Lots of questions keep coming up with every exam. So, with serotonin syndrome, it is a consequence of hyperstimulation of serotonin receptors. And it's a very classical triad of altered mentation, uh, which, for example, agitation, confusion, and seizures, autonomic dysfunction like nausea, diaphoresis, tachycardia, tremor, fever, and neuromuscular hyperreactivity. For example, hyperreflexia, clonus, which might also lead to hyperkalemia, acute kidney injury, and a DIC kind of picture. Now, what are the agents that are involved in serotonin syndrome? It is usually inhibition of serotonin uptake, for example, SSRIs, TCA, tramadol, pethidine, or increase in serotonin release, for example, amphetamines and ecstasy, and partial serotonin agonists, for example, LSD and buprenorphine. And how do you manage them? Firstly, is obviously withdraw the agent, activated charcoal for early presentation and supportive therapy in an ABCDE manner. Supportive care like rehydration, temperature control, control of hyper and hypotension, DIC, sepsis, and rhabdomyolysis. And benzodiazepine is the first line of agents for agitation, autonomic dysfunction. Limitation of opioids like fentanyl, very importantly, because they can increase the serotonin release. A general anesthetic may also be required with muscle relaxants for more severe cases. And the specific therapy is cyproheptadine, which is a serotonin antagonist, which can be used in very severe poisoning. Now, if you have to compare and contrast this with neuroleptic malignant syndrome, which is an idiosyncratic reaction to an antipsychotic agent, other drugs like metoclopramide, and rapid withdrawal of dopamine agonists, blockade of dopaminergic signal, and it's a triad of rigidity, fever, and autonomic instability. Other clinical features include confusion, drowsiness, raised plasma creatinine kinase, and white cell count. Now, this is a very important table which allows you to differentiate between the two syndromes, serotonin syndrome and neuroleptic malignant syndrome. Relationship to the dose, serotonin syndrome is usually dose dependent, whereas neuroleptic malignant syndrome is idiosyncratic. Serotonin syndrome has a rapid onset within the first 24 hours, whereas neuroleptic malignant syndrome is slow, usually takes days to weeks. Neuromuscular findings wise, it's hyper reactivity and increased reflexes in serotonin syndrome, and a muscular rigidity and reduced reflexes in neuroleptic malignant syndrome. Lab findings wise, serotonin syndrome abnormalities are not commonly seen, whereas in neuroleptic malignant syndrome, elevated white cell count and creatine kinase are important findings. Causative agents, why serotonergic agents are responsible for causing serotonin syndrome, whereas antagonism of dopaminergic pathways cause neuroleptic malignant syndrome. Management for serotonin syndrome, it's benzodiazepines and cyproheptadine, as discussed, whereas for neuroleptic malignant syndrome, it's bromocriptine and dantrolene. The resolution is also very rapid in serotonin syndrome, whereas it is slow, may take days to weeks in neuroleptic malignant syndrome. And lastly, mortality in serotonin syndrome is less than 1%, but it's much higher. In neuroleptic malignant syndrome, it's up to 10%. Management, again, withdrawal of the offending agent and supportive care, active cooling, benzodiazepine for agitation. And as for neuroleptic malignant syndrome, the specific agents include dantrolene, which is a muscle relaxant, inhibits the excitation contraction uncoupling, and bromocriptine, which is a dopamine agonist. Cardiovascular medications, which is the next topic. So the first one that keeps coming up is calcium channel blockers, very important one. Now, the calcium channel blockers can be classified into Dihydropyridines, example nifedipine and amlodipine, or non-dihydropyridines, example verapamil and diltiazem. What happens in an overdose? So, a patient coming with a calcium channel blocker or overdose, the clinical features will include hypotension because of vasodilatation and myocardial depression, arrhythmias like bradycardia and asystole, multi-organ hypoperfusion, which might lead to ileus, delirium, loss of consciousness, AKI, and might also, in very severe cases, present in cardiac arrest. Management wise, pharmacological, early vasoactive medications, catecholamines like adrenaline, isoprenaline, which cause positive inotropy and chronotropy. Phosphodiesterase inhibitors, for example, in milrinone and inoximone. However, there's a potential they may cause hypotension as well. And specific to calcium channel blocker toxicity include calcium chloride or gluconate. It causes positive inotropy and can be used as a temporizing measure. And alpha agonists, for example, of which increase the systemic vascular resistance, and vasopressin, which lead to vasoconstriction. Now, the specific its therapy is called early use of HIET, which is hyperinsulinemic euglycemic therapy. So this is very important. Again, it's quite a favorite topic. This keeps coming up in exams. Uh, High dose glucagon, positive inotropy and chronotropy. And the second line therapies include IV lipid emulsion, levosimendan, which is a calcium channel sensitizer, causes vasodilatation, and methylene blue. There is some role of atropine as a temporizing measure to counter the bradycardia. General measures, including echo, is very helpful in assessment, a consideration for early intubation, pacing. A VA ECMO may also be indicated in cardiogenic shock. Now, HIT, going back to HIT, it is the hyperinsulinemic euglycemic therapy. Indicated myocardial dysfunction. It facilitates intracellular transport of substrate and oxygen, and insulin causes calcium dependent and inotropy. Now, what exactly is it? So, first, you give insulin in a bolus dose of 1 unit per kilo. This is followed by infusion, example 1 unit per kilo per hour, and this is titrated every 10 to 15 minutes until you reach a heart rate of greater than 50 per minute and systolic blood pressure more than 90. And the usual rate is 1 to 10 units per kilo per hour. Okay. You administer 50% dextrose is administered concurrently, 50 to 100 ml. It's followed by concentrated infusion, 1 ml per kilo per hour of 50% dextrose. Close monitoring of blood glucose is necessary with a moderately high target until stability is reached. And of course, regular monitoring of potassium, especially you're giving so much insulin to ensure normokalemia. So potassium may need replacement in such cases. Coming to the second one, which is the beta blocker overdose. Glucagon and milrinone, they increase myocardial camp in positive inotropy and chronotropy. They treat the bradycardia and myocardial suppression, less helpful in vasodilatory shock, example, calcium channel overdose. Milrinone is an inodilator. Again, it may worsen the hypotension because of its dilatory effect. Useful in refractory bradycardia. Hemodialysis if hydrophilic, example, sotalol and atenolol. So beta blocker overdose, the treatment of choice is glucagon and milrinone. The next one is digoxin. Now, digoxin, as we all know, it's used commonly used medication for atrial fibrillation and also in case of heart failure. It has got a narrow therapeutic index. Levels are affected by altered renal clearance or metabolic enzyme inhibition or induction. GI upset is the most common one. It precedes neurological symptoms. GI upset includes nausea and vomiting, diarrhea, and abdominal pain. Cardiovascular, for example, bradycardia, AV block, junctional escape rhythm, tachycardia, and bigeminy. Neurological include visual disturbance, for example, color alteration, blurred vision, and diplopia. The management include measurement of digoxin level 6 hours post dose, reduce the absorption within 1 hour, and digoxin specific antibody fragment DGBind or DGFab. Now the next one is local anesthetic systemic toxicity. Again, quite an important one. This keeps coming up in the written as well as in the viva or in the form of scenario as well. So why do these happen? So the most common causes include overdose from a wound catheter, inadvertent intravascular injections, overdose from other procedures as well. They may have a delayed presentation due to a delayed absorption into systemic circulation, which may make it difficult to recognize. The clinical features for this condition are either neurological or cardiovascular. The neurological clinical symptoms include altered mental status, agitation, loss of consciousness, seizures, and respiratory arrest, whereas cardiovascular ones include bradycardia, heart block, asystole, and ventricular tachycardia. Now, procedure-related risk factors, for example, longer-acting agents, for example, bupivacaine and ropivacaine, CC to CNS ratio. So this is basically cardiovascular collapse. This is the ratio of the dose between the required to produce cardiovascular collapse versus induction of seizures. So bupivacaine has lower than lignocaine, so will more readily lead to cardiovascular collapse after CNS signs. And if it's a proximal regional blocks or continuous infusions, these are the risk factors uh, which make local anesthetic systemic toxicity more likely, or there's a tendency for it. Now, how do you manage a local anesthetic systemic toxicity? The key principles, obviously, firstly, to stop the injection, give lipid emulsion simultaneously. I'll discuss the dosage in a while. Intubation and ventilation and prolonged resuscitation efforts may also be needed. Other measures, for example, hyperventilation, reduce acidosis to improve contractility. Seizures are treated with benzodiazepines, thiopentone or propofol. Antiarrhythmics, avoid lignocaine, obviously, and eCPR may also be considered. And they need to be followed up to monitor for pancreatitis and report locally and to lipid registries. Obviously, you're using the intralipid, that's why. Use of IV lipid emulsions, 20% lipid emulsion is usually used. Give a 1.5 mils per kilo bolus dose for in a minute, and this is followed by an infusion of 15 mils per kilo per hour, and repeat bolus after 5 minutes if cardiovascular stability not restored or adequate circulation deteriorates. Maximum of 3 doses can be given in total. The infusion is doubled after 5 minutes to 30 mils per kilo per hour. And infusion should be discontinued when the adequate circulation has been restored or maximum dose is reached. Maximum cumulative dose is 12 mils per kilo. Coming to a very important topic called paracetamol toxicity. Now, this is the metabolism of paracetamol. So this is the most important bit, which sort of explains why the toxicity happens. As you can see in the upper part of the diagram, it's in a healthy individual. Most of the paracetamol is conjugated with glucuronide and is excreted in the urine, and the small percentage is conjugated to glutathione. However, in case of toxicity, if there's overdose of paracetamol, or in cases of, for example, starvation where the nutritional status is not that great, um, it is diverted. So impaired conjugation and depletion of glutathione. This results in accumulation of the toxic compound called NAPQI and acetyl P benzoquinone imine, which is a toxic compound which leads to all the serious side effects, which is namely hepatotoxicity. So as I explained, NAPQI production exceeds the available glutathione. Hepatic NAPQI levels rise and toxicity will occur. Degree of the toxicity will include like pre-existing glutathione depletion, for example, eating disorders, chronic alcoholism, HIV and cystic fibrosis, pharmacological induction of cytochrome P50, for example, in with use of medications like phenytoin, rifampicin, and carbamazepine. How do they present? So paracetamol overdose, usually they present, initial symptoms include are absent or vague, for example, nausea, vomiting. Hepatotoxicity, usually within the first 24 to 72 hours, presents with right upper quadrant pain, abnormal liver functions, and synthetic hepatic functions. There's a deterioration. For example, the INR is deranged. Elevation of plasma lactate. This is because of the impairment of mitochondrial function, anaerobic respiration, and has a consequence of hepatic failure. Kidney injury is common, occasionally predominant feature. The mechanism is slightly unclear. It may lead to a picture of hepatorenal syndrome. And fulminant liver failure, if hepatic injury progresses, which leads to jaundice, encephalopathy, coagulopathy, hypoglycemia, and multi-organ failure. Management includes the general principles of poisoning. Activated charcoal if presentation is within 1 hour of ingestion. And specific antidote is N-acetylcysteine or NAC. The initiation is guided by plasma paracetamol level on presentation, referenced against a nomogram. Right. So the management wise, activated charcoal and N-acetylcysteine. So the N-acetylcysteine, so that's a nomogram I was talking about. So the nomogram, so all patients with serum paracetamol levels above the treatment line, they have to be treated. Right. And time reference plasma above the level of treatment line comments on the NAC regime. If it's a staggered overdose, for example, the overdose has taken place over a period of time, they have to be treated, all right, with antidote regime, regardless of paracetamol levels at presentation. So if it's a staggered overdose, the level of presentation, the paracetamol level at presentation do not matter. The mechanism of action is it provides a reservoir of sulfhydryl groups which bind to the NACQI and stimulating production of glutathione. The side effects of NAC include rash, angioedema, and bronchospasm. And it's treated by slowing down the infusion and administration of antihistamine. The best outcome is achieved if given within 10 hours of ingestion, but considered effective for several days. Right? You can also have to refer to a specialist center. All right. Start early discussions with the liver center, especially if there's presence of acidosis, that's pH of 7.3 after fluid resuscitation, prothrombin of greater than 100 or INR greater than 6.5, and creatinine more than 300 millimoles per liter, and grade 3 or 4 encephalopathy. So if these are these features are present, that means it is meeting criteria for liver transplantation. So you have to speak to a specialist liver center. Salicylate poisoning, that's the next important one. So it's basically aspirin is salicylic acid. At toxic levels, this activates the chemoreceptor trigger zone, which leads to nausea and vomiting. And it also activates the respiratory center, which leads to hyperventilation and thereby respiratory alkalosis. High plasma levels, the mechanism of toxicity changes. It leads to uncoupling of cellular respiration and thereby and lactic acidosis. So it's interesting to note that it starts off as a respiratory alkalosis, but later on, because of the change of mechanism of toxicity, it actually leads to acidosis. Presentation and assessment. They usually present with fever, tinnitus, hypoglycemia, vertigo, visual disturbances, coagulopathy, and pulmonary edema. And management, activated charcoal and supportive management is the initial treatment. Forced alkaline diuresis, maintaining the blood pH of 7.4 to 7.5 and urinary pH of 6 to 7. And hemodialysis is indicated for cases with very high plasma levels. which is greater than 750 milligrams per liter, or life-threatening features. Now a little bit about organophosphorus poisoning as well. Now organophosphorus is, as we know, it's used mainly in agriculture. Nerve agents in chemical warfare, example sarin gas. The mechanism of action include they are inhibitors of cholinesterase enzyme. This leads to accumulation of acetylcholine, which leads to overstimulation of the muscarinic and nicotinic receptors. They're highly lipid soluble, readily absorbed from the skin and oral mucosa, rapid distribution, and easily crosses the blood-brain barrier, causing CNS effects as well. Now, clinical features, easy to remember. The mnemonic is dumbbells. So stands for diarrhea and diaphoresis. Urination, meiosis. B stands for bronchospasm, bronchoria, and bradycardia. E stands for emesis. L is lacrimation, and S is salivation. So dumbbells is the mnemonic for organophosphorus poisoning. Management. So again, management, firstly supportive and then specific. The supportive management includes skin decontamination, airway protection, gastric lavage, ventilatory support, inotropic, and nutritional support. The specific management include anticholinesterases, atropine and glycopyrrolate. Now, the dose of atropine is 2 milligrams IV, followed by 2 to 5 milligrams every 5 to 15 minutes until adequate atropinization occurs. And what do you mean by adequate atropinization? That is basically tachycardia around 100 beats per minute, moderately dilated pupils, reduction in bowel sounds, and decrease in bronchial secretions. You can also give atropine as an infusion at a dose of 0.02 to 0.08 milligram per kilo per hour. The cholinesterase reactivator, for example, pralidoxime, that is the other specific management. The way it acts is reactivation of the inhibited alkyl phosphorylated enzyme to its free active unit. You give it dose of 1 gram IV every 6 to 12 hours in adults, max dose of 12 grams in 24 hours, and 25 to 50 milligram per kilo in children. It's to be continued until adequate spontaneous ventilation is achieved. Now, propofol infusion syndrome. It is caused due to prolonged, which is usually more than 48 hours, infusion of high dose propofol. It's usually more than 4 milligram per kilo per hour. The way it happens is at the mitochondrial level, there's inhibition of respiratory chain and impaired oxygen utilization, and is more commonly seen in children. Clinical features include metabolic acidosis, rhabdomyolysis, bradyarrhythmias, progressive myocardial dysfunction. The management is firstly, obviously, get rid of the offending agent, which is propofol, stop the propofol. Supportive management, supportive ICU management in an ABCDE approach. And there is probably some role of extracorporeal removal of propofol has been proposed as a means of clearance. Now, what is TERP syndrome, which is transurethral resection of prostate syndrome? It's an intraoperative, it happens because of the intraoperative absorption of hypotonic glycine-based irrigation fluid through open prostatic venous sinuses. Irrigation of fluid, which is hypoosmolar, in comparison to the plasma osmolarity, glycine is also a neurotransmitter. Risk factors include duration, obviously longer duration, higher the chances, extent of resection, and the pressure of the irrigation fluid. The clinical features include volume overload, pulmonary edema leading to respiratory symptoms, can also lead to hypertension, bradycardia, chest pain, changes in plasma sodium content and plasma osmolarity, seizures, and coma. Management supportive, airway may need protection, seizure control with benzodiazepines, diuretics to treat the fluid overload, and sodium correction. Important to avoid rapid correction. Hypotonic saline is only in case of life-threatening neurological symptoms. Right. Is it been okay so far? Do you have any questions? because the next section is MCQs. So I'll try and make this as interactive as possible. All right. So let me get back to Zoom. So as I was saying, I will try and make this as interactive as possible. Okay, so the next section is MCQs. All right. So I have a list of 8 MCQs. So we'll go through them one by one. And um, if you think you know the right answer, or if you want to contribute, you're more than happy. Yeah, just shout out the answer or write something on the chat. Is it all right? Yeah. I hope all of you can hear me. Yeah. Just let me know. Give me a thumbs up or anything like that. Can you hear me? All right, then. The first one. Considering salicylate poisoning, which one of the following is true? Gastric lavage should be considered within the first hours of ingestion. Acidosis increases renal excretion. In cases of normal anion gap could be attributed to falsely high sodium concentration, and loss of hyperventilatory drive at intubation may precipitate deterioration and death. So, which is true out of the following 4 statements? Any ideas? So, you think D is the correct answer? Yeah, that is right. So, the true answer is D. So, well done. So, which one of the following is true is D. So, gastric lavage is within 2 hours of ingestion. That is false. Sorry, which is 1 hour. Acidosis increases renal excretion. Again, it's false. As we discussed, it's alkalinization. In case of severe overdose, a normal anion gap could be attributed to a falsely high sodium concentration. It's false. It's chloride concentration. So, as you know, the formula for anion gap, you must be aware. It's very important. It's sodium and potassium minus you subtract the chloride and the bicarbonate. So if it's a falsely high chloride concentration, then it will show a normal anion gap, right? And very correctly pointed. So it's a loss of hyperventilatory drive at intubation may precipitate deterioration and death. So that is true because the hypoventilation leads to acidosis and then loss of sympathetic discharge. Now, the second one, in case of quinine sulfate overdose, which of the following is true? QTC interval shortens, temporary deafness may occur. Amiodarone is the antiarrhythmic of choice for ventricular tachycardia with pulse. Quinine induces insulin resistance, and CVVH will remove quinine. Which of the following is true? QTC interval shortens, temporary deafness may occur. Amiodarone is the antiarrhythmic of choice for VTAC with pulse. Quinine induces insulin resistance, and CVVH will remove quinine. You're going for B. Anyone else? Anyone else apart from Omar? No. So again, Omar, you're very right. B is the correct answer. So in quinine sulfate overdose, which is following is true. QTC interval shortens. It's false. It prolongs. Temporary deafness may occur, which is true. It can also cause blindness. Amiodarone is the antiarrhythmic of choice for ventricular tachycardia with pulse. It is false. It's resistant to cardioversion by amiodarone. Quinine induces insulin resistance. That is false. leads to insulin release, which causes hypoglycemia. And CV, which will remove quinine, is false because it cannot be removed. Right? So well done there. Next one. Regarding botulism and tetanus. Botulism causes an acute ascending motor paralysis. Toxin bind irreversibly at the presynaptic junction. Diagnosis is through serum endotoxin measurement. Tetanus results in skeletal muscle flaccidity and autonomic instability. And high dose benzodiazepine therapy is a management strategy in tetanus, which is true. So, botulism causes acute ascending motor paralysis. Toxin bind irreversibly at the presynaptic junction. Diagnosis through serum endotoxin measurement. Tetanus results in skeletal muscle flaccidity and autonomic instability. And high dose benzodiazepine therapy is a management strategy in tetanus. Anyone taking this? No? Should I just move on? So the last statement, statement E, is true. So let's go through them one by one. Botulism causes acute ascending motor paralysis is false, descending. All right. Toxin bind irreversibly at the presynaptic junction, false. Toxin blocks acetylcholine release from the presynaptic junction. All right. Diagnosis through serum endotoxin measurement is false. It is through ELISA, electrochemiluminescence, and mouse inoculation. And tetanus results in skeletal muscle flaccidity and autonomic instability is again false. Rigidity it causes, not flaccidity. And high dose benzodiazepine therapy is a management strategy in tetanus is true. Okay, moving on. Right, so a 45-year-old man presents after ingestion of 50 tablets of 500 milligram paracetamol 6 hours ago. Which of the following is true regarding paracetamol poisoning? Serious liver damage is unlikely if N-acetylcysteine is given within 12 hours of ingestion. N-acetylcysteine must not be continued for greater than 24 hours. A pH of less than 7.3 on initial presentation is an indication for liver transplant. A raised ALT is the most sensitive marker. Now, which is true regarding paracetamol poisoning? Serious liver damage is unlikely if N-acetylcysteine is given within 12 hours of ingestion. N-acetylcysteine should not be continued for more than 24 hours. A pH of 7 less than 7.3 is an initial presentation is an indication for liver transplant, and a raised ALT is the most sensitive marker. Right. Okay. We have some answers coming. Anyone else? Is true. All right. So let's move on. So the answer is actually the first statement, A. So serious liver damage is unlikely if N-acetylcysteine given within 12 hours ingestion is true. So N-acetylcysteine must not be continued for more than 24 hours is false because it is indefinitely until improvement or transplant. All right. A pH of less than 7.3 on initial presentation is an indication for liver transplant is false. It is after fluid resuscitation, not on initial presentation. All right. And ALT is the most sensitive marker is false. It's prothrombin time that because we're looking at the synthetic activity of the liver. That is the most sensitive marker. Okay. Moving on. Fifth one. So regarding electrocution and radiation injuries, which of the following statements are false? Current flow across the chest of 100 milliamperes can cause ventricular fibrillation. Microshock can occur in the presence of a saline field central catheter due to low current density at heart. 1 gray is absorption of 1 joule of energy in the form of ionizing radiation per kg of matter. An exposure dose of 1 gray will result in a change in blood count. So which is false? Current flow across the chest of 100 milliamperes can cause ventricular fibrillation. Microshock can occur in the presence of saline fields. Central venous catheter to low current density at heart. 1 Gray absorption of 1 joule of energy in the form of ionizing radiation per kg of matter. An exposure of 1 dose of 1 Gray will result in a change in blood count. Anyone for this? Yeah. So it's actually the answer is B. All right. Because let's go through them one by one. Current flow across the chest of 100 milliamperes can cause ventricular fibrillation. It can, yes, so that's true. Microshock can occur in the presence of saline fields CVC catheter due to low current density because of the high current density, not a low current density. All right. 1 Gray is the absorption of 1 joule of energy in the form of ionizing radiation per kg of matter. That's true. And an exposure of 1 Gray will result in change in blood count. That's also true. Okay, so the answer is B in this case. Moving on, number 6, regarding industrial chemical poisoning, which of the following statements are true? Strychnine used in rat poisoning is a competitive agonist of the inhibitory neurotransmitter glycine. Laryngeal edema may be a significant problem in chlorine gas exposure. Anhydrous ammonia reacts with tissue water to form acidic solution, causing exothermic thermal injury, and patients with organophosphorus poisoning should be given fomepizole immediately. Which is true. You've got answers coming in. Yeah, so we've got an answer here. Anyone else? Omar is saying B. So it is actually B. So correct. Well done, Omar. So strychnine used in rat poisoning is a competitive agonist of the inhibitory neurotransmitter glycine is false. It's actually an antagonist. And laryngeal edema may be a significant problem with chlorine gas exposure is true. Anhydrous ammonia reacts with tissue water to form acidic solution, causing exothermic thermal injury is false. It actually forms an alkaline solution. And patients with organophosphorus poisoning should be given fomepizole immediately. Yeah, that's again false because the treatment, as we talked about earlier today, is atropine and pralidoxime. Now, moving on, the next one. Regarding biological terror attacks, which of the following statements are false? Category A biological weapons are those which can be easily disseminated. Anthrax is a gram-positive spore-forming bacillus. Treatment of anthrax consists of ciprofloxacin and doxycycline. Following exposure to anthrax, the incubation period is up to 2 weeks. Which of the following are false? Yeah, so the answer is, in this case, it's D. So, yeah, so well done to Abhishek. Yes, basically, false is we're talking about is category A biological weapons are those which can be easily disseminated is true. It's a anthrax is a gram-positive spore-forming bacillus. That's again true. And treatment it consists of ciprofloxacin and doxycycline. That's also true. And the following exposure to anthrax, the incubation period is up to 2 weeks. That is false. It's 2 to 60 days. All right. So the answer is D. So moving on, the next one regarding PRIS, that is propofol infusion syndrome, which the following statement is false. Incidence of 3 to 4% in adult intensive care units. New onset metabolic acidosis is usually a common presenting features. ECG Measure-Brugada syndrome changes with ST elevation. Severe head injury is a risk factor for developing PRIS, and in high-risk patient monitoring of triglycerides and creatine phosphokinase levels may stop PRIS from progressing. So which of the statements is false? Yeah, so we've got answers coming in. Yeah, so the correct answer is actually A. So you're right, Omar. It's actually less than that. It's around 1%. So with PRIS, incidence is around 1% in adult intensive care. It's much higher in children, though. All right, more commonly seen in children. A new onset metabolic acidosis, common presenting features true, renal failure and lactic acidosis. ECG may show Brugada syndrome with changes with ST elevation. That's also true. Other arrhythmias also occur. Severe head injury is a risk factor for developing PRIS. That's true. And in high-risk patients, monitoring for triglycerides and creatine phosphokinase levels may stop PRIS from progressing. That's also true. Let me check if I've gone through all of them or not. It looks like I've gone through all the questions. Yeah, right. So that's it really. So that's all from me. Those were my MCQs. Do you have any questions at all? Feel free to put them onto the chat if you want to. Any questions from today's session? No, in that case, I think that's it for now. All right. I think you can access these talks as well from the website. But if you have any questions, do let me know. All right. Otherwise, good luck with the exam. Yeah, reading sources. I used a lot of BJA articles, British Journal of Anesthesia articles, revision notes for intensive care medicine by Gillen and Campurata, and O's um, intensive care manual. There's another book which is quite common in the UK called the Final FICM Structured Oral Examination Guide. But I'm not quite sure if it's if it's used for EDIC as well. But definitely revision notes in intensive care medicine by Gillian, Wright, and Campurata. All right, so and lots of articles from British Journal of Anesthesia. All right then, so good luck and all the best. Do let me know if you have any further questions. All right, I'm going to stop sharing now.
Thank you, everyone.
Thank you. I think that brings us to the end of the class.